Good afternoon, everybody. Welcome to the East Tennessee Rural Health Consortium meeting. This is a quarterly event, so if this is the first time that you are joining us, please know that you are welcome to join us again in July about the same time. And this is the first time that we are trying a 1-hour meeting instead of a 2-hour meeting. So we do have an evaluation, a very brief one, at the end of our session today, and that is one of the questions. So let us know. Did you have enough time? Did you wish to have more? Or could it be even shorter? You want little short podcasty things, so we can explore all options. So thank you all for being here today. It is my great pleasure to introduce our speakers. I should first say I'm Lori Meschke. I am in the Department of Public Health and I am faculty, and I have the great privilege of being the project director of Courage and the director of the East Tennessee Rural Health Consortium. So our first presenter on the topic of harm reduction today is Joe Hoffman, who is the executive director at Live Free Claiborne. Joe is a native of Harrogate, Tennessee, and is a dedicated healthcare professional and community advocate with a passion for harm reduction. Since beginning his nursing career in 2012, he has spent more than a decade championing community health. In 2021, he earned his recovery coach certification, deepening his commitment to guide individuals through the challenges of substance use disorder toward healing and stability. In 2022, Joe became the executive director of Live Free Claiborne, a nonprofit organization dedicated to harm reduction and recovery. And under his leadership, Live Free has expanded access to life-saving resources, including overdose prevention tools, sterile supplies, and pathways to treatment. His work is driven by the belief that compassionate, evidence-based support can transform lives. And I would like to add that Joe was a recipient of a $400,000 award from the opioid abatement dollars of the state, which is extremely impressive. Beyond his professional advocacy, Joe serves as an associate professor of Bethany Church, formerly the Hill, Claiborne, for those of you who aren't familiar with the name change, in Claiborne County, where harm reduction and faith intersect in a powerful vision of human flourishing. He remains deeply committed to walking alongside those in need, ensuring dignity, hope, and support for every individual he serves. Joe, without further ado, I turn the floor to you, and then I will introduce Lucy before they begin. Thank you.
Thank you. And I would just, I'm not a professor, I'm a pastor. I'm not nearly smart enough to be a professor. So I'm going to request to share my screen, and I'm not sure which screen I'm sharing. Let's see here. Up, here we go. Okay, let me get over there and we'll begin. And can everybody see that? Okay, so as Dr. Meschke said, my name is Joe Hoffman. I want to start by apologizing for my voice. I'm a little under the weather, but any chance I get to talk about harm reduction, I'm going to take it, no matter how sick I am, given we have Zoom, and so I'm not going to get anybody else sick. So thank goodness for technology in that case. But yeah, I'm going to actually roll through my slides a little bit quickly, just to make sure that we have enough time for some discussion, and then for Lucy to give her presentation. So yeah, harm reduction. We're going to start from the top because I'm going to assume that you may know something about harm reduction, but just for in case you don't, we're going to start with a brief definition of it so that we're all on the same page as we move forward. Harm reduction, the general broad definition would be any process by which risk of harm is reduced when you engage in any activity that might involve adverse health outcomes. So my go-to example for harm reduction as a general, it would be seatbelts, because we can never guarantee that we're going to make it to our destination without incurring an injury, and so we mitigate that risk by applying a seatbelt to ourselves. And again, just to mitigate risk of harm. So seatbelts are a prime example of harm reduction. Other forms include cigarette filters, which that's a little bit ambiguous. We're not sure what all is in there, if it's better for you or worse for you. There's a bit of a debate there. But as a general idea, cigarette filters would be considered a form of harm reduction. surgical masks and PPE. Every time a physician dons gloves to perform a procedure on a patient, they are engaging in harm reduction, again, mitigating risk of harm. Contraceptives, diet soft drinks, insulin, and anything that would reduce risk of harm and any behavior that would pose a risk of adverse health outcomes. When you're talking about harm reduction when it comes to working with individuals who are actively using substances, we can narrow down that definition just a little bit more. In these cases, harm reduction is an evidence-based approach that is critical to engaging people who are actively using substances and equipping them with life-saving tools and information to create positive change in their lives and potentially to save their lives. Again, keeping them safe, reducing risk of harm. So, in the cases of persons who inject drugs, harm reduction looks like sterile syringes. We do not want to introduce a non-sterile item into the sterile field of the interior of a vein. And so we provide individuals with sterile syringes so that each time they use that syringe, they are at a much less risk of incurring an infection. Sterile water, these individuals need a clean way to mix their substances. We don't want to use a water from a water bottle that someone has already taken a sip out of because there's obviously germs in our mouth, and we don't want to introduce those germs to the interior of your vein. And so sterile water is an example. A clean way to mix and heat substances. So sterile cookers. We've seen the TV shows where the individual may have a spoon or something where they use to mix and heat their substance. We don't know where that spoon has been. We don't know. Obviously, it's not sterile. We're not even sure if it's clean. And so we want to provide individuals with a clean way to mix and heat their substances. Again, reducing risk of infection. Wound care kits, alcohol prep pads, antibiotic ointment. We want to make sure that injection sites stay clean and we can promote healing and increase our healing factor in those cases, especially when you're dealing with substances such as xylazine, which is a vasoconstrictor that is now being cut with a lot of drugs that are on the street. It inhibits blood flow to the injection site, and we're seeing some pretty bad wounds. And so we want to give these individuals a method and information on how to keep that injection site clean and again protect their health. Fentanyl test strips, and I haven't updated my slide yet, but I'll include in there xylazine test strips too. People have the right to know what they're putting in their body, and so we want to provide them with these test strips so that they can test their substance of choice to see if these components are present or not, and then make appropriate decisions regarding their health. When I gave this kind of rundown at the hospital, because I work closely with Covenant Health, one of the questions that was asked was, well, are individuals really making better decisions if they know that there's fentanyl present? And the answer is yes. UT actually came out and did a study with our participants, and more than 70% of them said that if they find that there is fentanyl present in, for example, their heroin, they either dial back the dose or they throw it away because it's poisonous. It's killed people that they love, and they don't want that to happen to them. And so, again, these are human beings and they want to they want to have life and they want to have quality of life, and so we're just equipping them to advance that as much as possible. Obviously, Narcan, overdose reversal medication. People have the right to choose what they do with their bodies. We just want to keep them as happy and as alive as possible while they're engaged in that. Access to Hep C and HIV testing. We do point of care testing at our harm reduction facility because the truth is, if people know that they are positive for either of these viral infections, they do change their behaviors because they interact with people that they care about. If they know that they're positive, they're less likely to share a syringe with someone who may be negative. They're less likely to have unprotected sex with another individual if they know that they're positive. Again, we're restoring dignity, increasing value, and we're educating people so that they can make good decisions about their health. Safer sex kits, condoms, and dental dams. And one of my favorite connections to caring relationships. We greet people at our harm reduction program with a smile, with a non-judgmental attitude. That's one thing that we really impress upon our employees and volunteers is that you're going to see things that may be very abnormal for you, but we're going to smile anyway. We're going to make sure that people feel welcomed and comfortable and loved while they're here, so that when and if things go sideways in their lifestyle, they know that they can call us without any judgment and get help and get connected to whatever resources that they need help with. So then we get to the question, is addiction a moral failing or a disease? That really is the question that creates either creates stigma or removes stigma. So just to answer that, in the Surgeon General report published in 2016, addiction is defined as, quote, the most severe form of substance use disorder associated with compulsive or uncontrolled use of one or more substances. Addiction is a, emphasis mine, chronic brain disease that has the potential for both reoccurrence, which is relapse, and recovery. So, according to the Surgeon General, addiction is a physiological disease. It's a hijacking of the chemicals that are found within our brains, and individuals who are living with substance use disorder are in need of health care. They didn't choose to be there. And if you would argue that it was a choice, in my honest and experiential opinion, that choice was made for them. When we factor in what we know about social determinants of health, adverse childhood experiences, genetic predisposition to addiction, um, people have risk factors, whereas other people do not have risk factors. And I could go on and on about this, but for time's sake, we'll keep going. But just understand that um, the case of me and my wife, I didn't have the same risk factors in in my life as she did growing up. And she's actually worked with me with our clients before and said, you know, I love what you do, but I need to take a step back because this very easily could have been my story. And it just hits really close to home for her. Again, just some real life example. Harm reduction and faith. And really the reason I have this in the presentation is I developed this presentation geared more towards talking to bodies of faith to help them become more comfortable and on board with harm reductive measures. And so, if you're not a person that ascribes to a faith, or if you're a person that ascribes to a faith that's different than mine, that is totally acceptable. There is no, you take the meat and throw away the bones, as they say. You take what's useful and valuable to you. Whatever you leave on the table is perfectly fine, and there is no judgment or offense taken on my part in that case. But let's agree that we don't have to believe that something is true in order to glean truth from it. So take what is valuable here. So let's look at really quickly the story of the Good Samaritan found in the Christian Bible. So Jesus, the leader of the Christian faith, gives this example of an individual who leaves Jerusalem and he's going down to Jericho, and he's happened upon by thieves and robbers, and they become physically violent. They beat him. They take everything he has, and they leave him for dead in on the side of the road. And people that you would think would help this individual actually kind of made it not their problem and avoided it. But then the person that you would least expect, the Good Samaritan, sees this individual who's in need of help and spends time, money, and effort in order to reduce harm and to provide healing for this individual. Now, the reason that this story is so relevant to harm reduction is when we read this story at face value, we sometimes assume that the Good Samaritan had all the information that we had. See, because we can look at it from up here looking down, and we can see what happened to this man and how he ended up in the position he was in. And so it makes sense to us that, yeah, of course we would help this person. This person is a victim, and so it's easy to help this person who is a victim. But the Good Samaritan doesn't have all the information that we have. The Good Samaritan has no idea how this man ended up in the ditch. Um, this man could have been the perpetrator. He could have tried to rob someone and was overpowered by his victim. This man could have a mental health challenge that caused him to put himself there, to harm himself. There are 1,000 different factors that could play into how this person ended up in the position they were in. And the point that Jesus is making is that it doesn't matter. It's not our job to determine whether or not a person deserves support or health. It's our responsibility as a human being to see harm and take measures to reduce that harm when we see it. The most important thing that I want to emphasize in the story is that not only did this Good Samaritan not know how the man ended up in the position he was in, he also didn't know how quickly he would end up back in that same position. Because if that man suffered from mental health challenges that may cause himself to harm himself, it could be less than a week before the man's back in that position. But again, it doesn't matter. What matters is we're human beings, and because of that, we have value, and because of that, we deserve care regardless of how we ended up in the position that we are in. So that's your little faith-based portion of it. I'm going to look at my time and see how I'm doing. Okay, we're doing okay. So if we can't get behind harm reductive measures regarding the fact that it is a disease, that it's not a choice, and that individuals are in need of care, and if we can't get behind it when it comes to our responsibility as human beings, then let's look at some empirical data when it comes to harm reduction. So, harm reduction has a long-term impact on drug use. For example, new users of syringe exchange programs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs altogether than those who don't. I would attribute that directly to the relationships that are built. I'm sure there's 100 other factors that can play into that. But I just know that from experience working with our participants at Live Free Claiborne, we build relationships with individuals, we restore value. And because of that, we see people who maybe would have never entered into treatment, we get to walk with them into treatment. And so I think that care and relationships go a long way when it comes to that statistic. Syringe exchange programs prevent overdose deaths when within its community by providing education and supplies to persons who inject drugs. We'll get into the numbers for a minute, but Live Free Claiborne is responsible for hundreds of overdose reversals within and around Claiborne County, and we're a very small office with 2 full-time employees and 2 part-time employees. So with just a couple of people and plenty of passion and support from others, we can make huge differences in our communities. Again, we just have to have that desire to put ourselves in those positions. Syringe exchange programs help protect first responders and the public by providing safe disposal of used syringes. We give people a good reason to hold on to their used syringes. We strive for a one-to-one exchange, and so we tell people we're going to give you 30 syringes today. I need you to bring those back to me next week, and then we can swap them out for unused syringes. And so they keep them in bottles or sharps containers, whatever they can manage. We see them come in gallon milk jugs and laundry detergent bottles, but nonetheless they're in hard plastic containers, and they are then appropriately disposed of rather than just being tossed in the trash where you could incur a needle stick. So yeah, we give people a good reason to properly dispose of those. Long-term impact on taxpayers. So if we can't get behind it on those grounds, then let's look at the finances. So current cost for hepatitis C treatment is up to $84,000 per person. That's a 12-week course of treatment, which is very, very effective. It's very, very effective. But nonetheless, it is very pricey. The average cost for hospitalization due to endocarditis, just needing IV antibiotic therapy, is averaging about $50,000, excuse me, per person. If that progresses and they need heart valve replacement surgery, we're looking at between 80 and $200,000 per person, and that's the only cure for chronic endocarditis. HIV treatment includes lifelong maintenance drugs averaging between $1,800 and $4,500 monthly per person. And a study done in 2020 found that harm reduction services reduced the risk of infection of Hep C and HIV by up to 90% in rural counties. And here's the big number: 95% of Live Free's participants either have state-funded Medicaid or are uninsured, which means when this person who does not have access to harm reductive services does get sick, does present at the emergency department, that cost will fall on taxpayers because that's a burden on our healthcare system. Whereas we can spend much, 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 much less money, and an ounce of prevention is worth a pound of cure. I may have said that wrong, but you know the meaning. You get the meaning. And then there's the argument of, oh, well, we don't have that here, which I was in a meeting earlier this week, and that was kind of the jargon, the dialogue of, oh, well, I can't see a source for that, and so I don't believe that. Well, there are sources for it. You just have to look for it. So this was a study done in 2015 by the CDC. It was a study meant to identify vulnerable counties when it comes to the risk of HIV and Hep C outbreak. Claiborne County ranks 80 among 220 counties listed at risk. Granger County is 66 at risk. Campbell 46, Union 74, Lee County, Virginia 73. Hancock County ranks 13, and Bell County, Kentucky ranks 6, most at risk for Hep C and HIV outbreak. Um, we have a method that can be used to prevent the spread of disease in our vulnerable communities, and it's proven to work. And if we ignore it, we're gonna have major problems. I wish there was a more eloquent way to say that, but that's just the truth of it. Harm reduction works, and if we can change our conversations and educate our communities about it, we're gonna see these numbers go down very, very quickly, very quickly. Um, we can use Scott County, Indiana as an example. So in 2015, Scott County, Indiana suffered an HIV outbreak directly linked to intravenous drug use. And the recorded cases exceeded 200 by the time it was quelled, but it was 100% due to intravenous drug use, the sharing of syringes. Because you think of the spread of Hep C and HIV, you think, okay, it's an STI, so we're looking at unprotected sex. That's not the case. Typically, the mode of transmission in these viruses is through the sharing of needles. I'm not going to play this video just for time's sake, but this is Scott County, or excuse me, Governor of Indiana, Mike Pence. During that time, he actually declared a state of emergency because of this HIV outbreak. So I encourage you to, it's a quick YouTube search and listen to that video, and they go into detail on how it was spread specifically through the IV drug use and not sexually transmitted. So these are cases, epidemics that we can prevent just by supporting and hosting harm reductive services in our communities. Today. So, how am I on time? Okay, we're doing good. Cool. A few numbers from Live Free Claiborne. Again, we are a very small office, 4 employees, some volunteers, and 3 offices out of Bethany Church. So since 2022, we have safely collected and disposed of 124,000, almost 125,000 syringes, distributed 2,600 units of Narcan, preventing more than 349 overdose deaths, and connected more than 50 individuals to recovery services, and built numerous relationships with individuals in active addiction. We're still in utero. We are still very young and developing, but this is the kind of impact just a few people and a passion to see change in their community can have. We can make a difference in the lives of individuals who are most vulnerable in our communities. We just have to have eyes to see them and hearts to love them. So what does it look like? If you were a person in active addiction and you came through the doors at Live Free, you're going to be introduced by the greeter, who's going to tell you a little bit about what we are and what we do. They're going to work to make sure that you feel comfortable and safe, and make sure that you know that you're not going to get in any trouble for coming to see us. They're going to assign you a syringe exchange program ID card, which will be a specific ID number. That way we can actually track how many times you've been to our exchange site, how many syringes you've deposited, how many you've received, without us having to take any personal information from you. Our program is completely anonymous. People do not have to render any information whatsoever, save for a few numbers and letters for us to be able to assign them an ID. And again, this is our effort to make sure that we're protecting their identity and keeping them safe and making sure that they feel comfortable while they're there. Over on the other side of the screen there, you're going to see some of the supplies you're going to gain access to. So in the top corner over there is our OraQuick Hep C and HIV rapid testing kits. We actually facilitate these kits, these tests for them. Again, it takes about 15 minutes. It's a little finger poke, and then they know if they test positive or negative for HIV or Hep C antibodies. And then again, if they are positive, we connect them to follow up testing at the local health department and then get them on a track for treatment. Right below that are some of our fentanyl test strips. I have to make sure I remind everybody this test your product, not your pee. This isn't going to help you with your job interview tomorrow, but it will tell you if there is fentanyl or if it's a xylazine strip, if there's xylazine in your heroin, in your methamphetamine, whatever your substance of choice is. Right in the middle there is a unit of Narcan that they gain access to. We do a quick training with everyone that receives this Narcan to make sure they know how to use it in the case of an emergency. Right below that is some of the injection supplies. I wanted to put the syringes in there specifically. I hope that's not triggering to anybody. I think it's important for us to see and understand that these individuals, they're using insulin syringes, very, very tiny, small insulin syringes. Because if you hear a news report or read an article about intravenous drug use, they're going to get the biggest needle, a picture of the biggest needle that you've ever seen, and put it up on the screen. And it's called rage baiting. It's meant to stir up emotions and get clicks. And I can't believe they would use something like that. Well, the honest truth is they won't. They prefer the little tiny ones because they're human beings, and if they get poked, they hurt. And they don't want to hurt. So, yeah, just keep that in mind. Little 1 ml, 100 cc insulin syringes. Condoms, lubricant, a little injection packet there with some alcohol, antibiotic ointment, Band-Aids. And these are just some of the supplies that they gain access to. Here are some of our volunteers. Over on the one side, we have Miss Laura, who she's actually, her husband recently retired, so she is on the road traveling right now. We said go in peace and have fun, but she would typically do our sign in and get people assigned a number. That's Robbie Campbell, who works for Revolution Health Services. He comes down whenever he has some free time and is just a presence. We have multiple volunteers that may not even have anything to do, but they go around and talk to people and just make sure people feel welcomed and comfortable. And over on the other side, we have Miss Lila there behind the desk. She's our harm reduction specialist. She does all of our Hep C and our HIV testing. And on the other side is one of our participants. We've been serving this individual for several years now, and I'm happy to report that I got the text from our local navigator this morning that she was admitted to treatment today. So, again, that's just one of those cases where we can build relationships and work with people and encourage them and help them into a better quality of life. We now have a van, and so we are transporting people to and from relapse prevention groups, evidence-based treatment, and we are working on setting up mobile syringe exchange at this time. So we're very excited about that. And then on the other side, there is our food pantry. People don't just gain access to injection supplies. We have a clothing closet, a food pantry. We want to take care of all of their basic needs, even down to serving coffee. We serve coffee and have conversations with them, and sometimes we'll have someone from the church bake and have snacks. We had a volunteer buy pizza for everybody this past Tuesday, so everyone got a slice of pizza as well as their injection supplies. Again, just to restore humanity and dignity and take care of some of these basic needs for these individuals. It's time for a change. It's time for healing. And through education, awareness, and compassion, we can break the cycles of addiction and bring healing to our communities. We have to be the change we want to see. We have tried the just say no and the war on drugs, like all the things that we thought were going to work in the past. They've obviously not worked. We've learned more about addiction since then. And so we have to change our approach to how we look at addiction and how we support individuals who are in active addictions. I know that was fast. I wanted to make sure I could get through all my slides and make sure that we had some time for questions and discussions. So at this time, I will open it up. If you have a question, you can throw it in the chat if I can find the chat, or unmute. It might be better unmute. I can't even see chat right now.
Thank you so much, Joe. It was a very, very informative and really inspiring presentation. And I was so impressed by all the services and the manner in which you distribute your services to your community. Troy, first question.
Oh, yes, Joe. I'm curious at my questions are financially based, and I'm curious at how much the comprehensive kits cost in terms of the harm reduction supplies, and then how I don't know where your funding comes from. I know some of it from the abatement stuff, but I didn't know how sustainable your program seems to be. Is this something that you can definitely say is a long term? You don't need any like particular planning for finances to be changed or anything like that?
It's an excellent question. So it's really interesting. Before we got our abatement grant, we were funded pretty much, I would say 90% of our funding was through the Tennessee Department of Health. They funded things like salaries, basic supplies, things of that nature. However, you can't use taxpayer money to buy syringes because it's considered drug paraphernalia and people don't really like that. And so we had to come up with our own funding. We have another grant through the Tennessee Department of Mental Health and Substance Abuse Services, which actually would give us a kickback every time we did case management with a client, helped someone along a pathway of recovery. And that was unencumbered funding that was coming in that we could use then for the purchase of syringes in that case. Now, with the abatement grant, we actually included in that budget to use a portion of that grant to purchase syringes. So that is a burden that has been lifted off, at least for the next 3 years. We don't have to worry about that. We are working right now on sustainability. We're planning fundraisers. We do have people in our community that do support us. There's a local philanthropist who loves what we do, and he supports us a little bit each month. Bethany Church supports us with some funding. And then the wonderful thing is things like naloxone is provided by the Tennessee Department of Health, so we don't have to purchase that ourselves. Now, Band-Aids, ointment, things like that. We've actually worked with the Courage Grant with some funding to get some of those medical supplies in to beef up our injection packs just to make sure people are protecting their health in that way. So the stress of the financial burden is not nearly as much as one might assume. Nonetheless, we are looking at sustainability plans because we want to be here for the next 15 years if the need is here. Ultimately, the goal is to not even have to have a syringe exchange. But we have to think realistically, and we plan to be here for the next decade and a half at least. At least. Jonathan?
Hi, I just want to say thank you for a great presentation and also good seeing you again after the Hamlin County Anti-Substance or the Substance Use Prevention Coalition.
Yes, sir.
My question is, well, I'll give a little bit of context. So I work for a suicide prevention program, and we approach harm reduction through the lens of like counseling on access to lethal means. So how do we keep people, or how do we work with people to where they voluntarily like keep themselves safe from the things they would use to hurt themselves. And
Mhm.
something to that effect that I would really like to start
I think you froze.
doing is offering naloxone. I was wondering what kind of do you need a special certification to do naloxone training? I've been naloxone trained, so like what is the process there?
So it's really interesting since we are a harm reduction program sponsored by the
Mhm.
Tennessee Department of Health. Our Narcan training is not like it's not a certified like, hey, you can
Okay.
go out and train other people now. It's a quick 3 minute, here's the recovery position, here's what you do, here's
Okay.
how you use it. Basically, we read them the instructions that are on the box of the
Okay.
naloxone. And so it's not a certified thing. If there's a need, all someone has to do is come in and say, I need Narcan. They don't even have to be in active drug use. We've had
Okay.
mothers with young children. They said, we've got opiates in the house, prescription based, but just in case a child, can I have some Narcan? Absolutely. Let me show you how to use it. This is what you do in this case.
Okay.
Because of that, one of our biggest emphases is call 911. Like
Yep.
that's the first thing, call 911 and then you get your Narcan out. We want to make sure that we get the professionals there as
Yep.
soon as possible. But here's a crash course in that case.
Mhm. Absolutely. Thank you.
Great question. Cassidy?
Hey, so I wanted to say one thing. You were talking about them preferring insulin syringes, and I can say from my experience of living in a very rural county, when there is not an SSP program in place, you are left with very little options. And I know that there are people that have had to resort to going to like a Tractor Supply and
Yeah.
inject away, and that is just another reason why I'm so supportive of what you do. But my question is, how did you all start? Like, was it literally like one or two people? Like, what did the very beginning look like?
It's a great question. So, it was born out of Bethany Church. At the time, it was the Hill Church, and it started as just a peer-led relapse prevention group. So we had somebody who was in recovery who wanted to support other people. They said, "We're going to meet here on Tuesday nights just to have this discussion to support recovery and sobriety." That grew and grew, and we saw the bigger need. Thought, okay, so we need to take this and really, because there's really not much else going on here in our community, and grow from there. So the really interesting part, and this is what I try to encourage people with, is we weren't harm reduction specialists. Like, we were just churchgoers who wanted to make a difference. And so we got connected to the right people. We learned, we were malleable, we were changeable. Like, we tell us what works and we'll change to suit best practices in that case. Got our 501(c)(3) nonprofit status, and just got educated on the fly because there is such a need for it. And I hope that doesn't remove your faith in us as, harm reduction specialists. Now it's all experiential. And the reason I use that to encourage people is you can make differences in your community. All you have to do is have that passion and that drive behind it, to make those differences. You just gotta go and do it.
Awesome. Thank you.
Yes, ma'am.
Thank
Anyone
you.
else have any other questions?
I think we have to move on to our next
Okay,
speaker.
perfect. Perfect.
That's
Thank you all
okay.
so much.
Thank you, Joe. I just want to put in a plug too that we are currently working on with Joe being one of the co-principal investigators on this. We are putting together a Samaritan toolbox, which will be all the how-tos in creating a faith-based harm reduction program in the state of Tennessee. So it'll tie in the legal aspects, the stigmatization, faith. It'll be non-denominational, and then of course, evidence-based practices. So that is forthcoming. Our next speaker is Lucy Langley. They are a college scholar at the University of Tennessee in Knoxville, and they also serve as a research assistant in the East Tennessee Rural Health Consortium's Courage Project at the University of Tennessee in Knoxville. For 3 years, Lucy has assisted with many projects and website maintenance. In May of 2024, Lucy received an award to study harm reduction vending machines in rural East Tennessee communities. In addition to research, Lucy has volunteered with organizations like the East Tennessee Harm Reduction and Metro Drug Coalition. At the University of Tennessee, Lucy is studying environmental health design to understand the built environment's role in addressing substance use. They will graduate in May 2025. In their free time, Lucy serves as an lived experience foster care advocate through policy and public engagement to improve the lives of foster youth. Lucy, without further ado.
Awesome, awesome. Thank you for the lovely introduction. So, cut to the chase. Want to say thanks. Thank you, everyone. And especially HRSA and undergraduate research, and especially Courage. Love y'all. So, starting off, what's the background? Opioids in East Tennessee. So, first of all, East Tennessee was specifically targeted by pharmaceutical companies, specifically in oversupplying of physicians and pharmacies. We also have nearly half of the total fatal overdoses here in East Tennessee. We also have the highest prevalence of neonatal opioid withdrawal syndrome. So we kind of covered harm reduction. Thank you, Joe. And again, it can include things like sterile syringes, sharps disposal, first aid, food and water, and naloxone. So let's talk about staffed harm reduction services in East Tennessee. So these are organizations like Joe's and others that provide harm reduction services to folks. But only 27% of these staffed harm reduction services exist in rural East Tennessee. or rural Tennessee. That means 73% aren't in the areas where they're needed most. So there's this really cool tool called a harm reduction vending machine that can help alleviate some of these barriers and dispense harm reduction and overdose prevention resources. They're portable, they're unstaffed, they're available 24/7, and they're much more accessible in these areas. So a brief background in the history of these harm reduction vending machines. The first harm reduction vending machine was operated in Denmark in 1987, but they didn't come to the US until much, much later. So the first harm reduction vending machine in the US was in Puerto Rico in 2009. That was operated by a harm reduction organization, much like Joe's. So much like the services provided at a staffed harm reduction organization, they can help reduce HIV and Hep C transmission. They can increase access to harm reduction services. They can boost client engagement, and they can help people feel more capable in addressing their own recovery journey. So what are the barriers? Usage of these harm reduction vending machines is still pretty new. If they only came to the US in 2009, we still have a long way to go and a long way to implement these harm reduction vending machines in different areas. Stigma is a huge barrier to substance use disorders and recovery. Both clients feel self-stigma, and they can also feel stigma from the community. This pressure can make it hard for them to access recovery resources. Cost. One of these harm reduction vending machines that are refrigerated can cost over $7,000. And another thing that is still being kind of discussed is the placement of these harm reduction vending machines. Do you place them indoors or do you place them outdoors in a more public space or a more private space? All of this has its own kind of challenges: indoor, outdoor, public, private. So let's talk about rural harm reduction vending machines. There's not a lot of research about harm reduction vending machines in rural communities, especially since rural communities face different challenges. And also, their lived experience is not included, especially folks who use drugs in rural areas. So this study kind of started off with the question of, how do we assess harm reduction vending machines in rural East Tennessee? And how do we include the perspectives of both staff and clients? So we had 9 clients and we had 7 staff of harm reduction services in East Tennessee. We recruited participants on site at a harm reduction service organization, also via social media and email. Participants went through a consent process, then completed a 10-minute online survey, followed by a 30-minute interview. Afterwards, we did something called thematic analysis, where we go through the interviews and try to figure out what's going on. Is there a theme? Is there something that everybody is saying or something that different groups of people are saying? So out of this, we came up with like 5 themes. Awareness. Do they know about a harm reduction vending machine? What would they put inside of a harm reduction vending machine? Placement. Where would they put a harm reduction vending machine? Security. Why would you put the harm reduction vending machine there? Do you have any concerns? And then public reaction. How do you think the community is going to respond to a harm reduction vending machine? So starting off with awareness, only 11% of clients knew of harm reduction vending machine, whereas all of the staff knew about harm reduction vending machines. A really interesting quote that I noticed from the client who knew about harm reduction vending machines is, I've seen them on like websites and stuff, but not like seen them face to face. And I think that's really interesting because that shows they're aware of it. They've been navigating online spaces, but that they don't have this in their area. And then staff oftentimes engaged with harm reduction vending machines at their places of work. So when it came to inventory, it kind of boiled down to two groups: safe use and basic needs. If you look at this graphic here, in the background, you'll see yellow. That is kind of the items that clients listed. And if you look at the blue, that's what staff listed. But that little green area in the center is where they matched up a lot. As you can see, they kind of aligned on a lot of things, but things like support resources and hygiene supplies were not being matched as much as, say, food and water, which wasn't mentioned a lot, but when it was, it matched up very heavily. And staff really kind of supported things and everything that basically is provided at a harm reduction service provider's office to be included in these harm reduction vending machines. So everybody wants to know, what about the syringes? Well, everybody loved this, the SSPs, or like the exchanges, but there was kind of some conflict and some disagreement sometimes. And mostly that was guided by concerns of security. Placement, there were a bunch of categories where everybody kind of agreed: hospitals, pharmacies, domestic violence shelters, firefighters, bars, and then recovery supportive churches. But specifically, the Blessing Box, which is kind of like a community pantry that's free, often operated by faith-based organizations. There were some challenges, though, when people were thinking about placement. Transportation played a huge role in where people wanted to place these harm reduction vending machines. But also law enforcement, people were kind of concerned about, hey, is using this machine going to get me in trouble? And so they were really worried about themselves. The same thing kind of happened with faith-based organizations and churches. Children were a really interesting kind of placement where everybody said, hey, I don't know if you should place these near parks or schools. I'm really worried that a kid is going to be seeing substance use, or maybe they're going to get hurt. The difference between law enforcement and schools and parks is that one of them was a fear for themselves and the other was a fear for others, for the most vulnerable, for children. And I think that's a really important point to kind of hammer in, because they're people. You know, these are just folks like you and I who are concerned about their kids and other people's kids, just like you and me. And preserving that humanity and understanding that people are people, regardless if they use substances or not, is really important. Security. We talked about this a little bit earlier, but security guided both placement and inventory. And folks, staff and client alike, had similar but different perspectives. Some people said, hey, I'm worried it's going to get vandalized by folks who use it and folks who maybe don't like the vending machine itself. Maybe put it in public, maybe not. But it also included social and legal concerns. People were worried about being judged by the community, and people were also worried the machine itself would be legal. So law enforcement, again, that was a huge kind of concern. Where 50% of clients and 43% of staff felt that it was going to be negative. Staff oftentimes had a positive kind of spin on it, saying, hey, maybe if we tell them that it'll reduce litter, it'll increase their safety, it'll improve that relationship, and maybe there'll be a positive outcome. Faith-based, again, over 50% of clients and staff felt that it would be a negative reaction from faith-based communities. Over 2/3 and slightly under half of staff felt that the community would respond negatively towards harm reduction vending machines. So when it comes to harm reduction vending machines, first of all, we need to educate both clients and staff and community members about what is a harm reduction vending machine and is it legal and how does that work? Navigating those complexities is important for everybody in this equation. So we need to host community conversations and dialogues. Before implementation and during planning, we need to engage with law enforcement. We should also consider placing harm reduction vending machines outside. So that way there is more access for folks. And then also, we need to be selective of faith-based involvement in the implementation of harm reduction vending machines. There's kind of a mixed bag, and we need to be, again, aware of what the folks that we serve are needing and where their comfort is at. And then that's all I have, and I appreciate it.
Thank you so much, Lucy. Excellent information. I now turn it over to Troy with our first question.
How's it going? I think these vending machines are a wonderful idea, but are the designs for the vending machines fully fleshed out? Like one thing I was considering with how you were talking about kind of the supplies that people were talking about putting in the vending machines is either putting them in locations in par with like having the Narcan and supply vending machine and then having a normal vending machine right next to it. So it kind of gets a bit more normalized, maybe attracts more people to naturally go up and see them. Or is there a way to potentially, if they're not fully designed, since they have to be cooled, you could add, people add water, could put water bottles or even other beverages in the vending machines, and then the machine should hopefully be able to identify if it's something you would have to pay for, like maybe if they want a Sprite or something, and then they can get their supplies as needed, and that quarter $1.25 that they put in for the Sprite can be put back into funding for more supplies and other things potentially.
I had never considered putting both, like the Coca-Cola and the naloxone in the same kind of machine. But yeah, harm reduction vending machines they're associated with that kind of Coca-Cola machine, but they also, some folks have been taking like magazine racks, where you open it and you close it and you can get your magazine out. And they just, put those as nalox distribution boxes. I think that sounds like an excellent idea. But yeah, I mean, they are fleshed out, and there's lots of different people using them. Some of them they have little ID cards. Some of them you enter in a zip code, and it dispenses like say the naloxone for free.
Interesting. Thank you.
Any more questions for Lucy? Okay. At this point, I would like to thank you all for joining us this afternoon for our first ever 1-hour East Tennessee Regional Health Consortium meeting. We hope that you found this session very informative. I know I always can learn something in this area. And I hope you will take the time, because as I mentioned, we're changing our format and we would love to hear your feedback. We would also like to get ideas about getting the word out, because we always do have really knowledgeable presenters at our workshops, and we would like to get the word out more. So if you have ideas about marketing that you would like to also add in our survey, we welcome that and any other suggestions you may have. So without further ado, please keep your eyes peeled for our next meeting, which will be in July. And the survey also asks if you have topics that you might like to have addressed in relation to substance use disorder, its ramifications and factors associated with it. So with that, I wish you a very lovely weekend. And I look forward to seeing you at the next meeting. Bye-bye.